Okay.
Hello and welcome back to Misconceptions. So glad to have you back for another episode and exciting, interesting, and hopefully kind of thought-provoking conversations around perinatal and reproductive mental health. Today, I have the opportunity to sit and talk with a friend and colleague and therapist, Hilary Waller. Hilary and I have met a number of years ago and have continued to kind of be in similar and shared circles, but mostly in similar passion around the work that we do. And I'm excited to welcome you here today. Thanks for coming, Hilary.
Thank you so much. It's such a pleasure to be here. Truly, truly a pleasure.
So great. We are going to be talking today around, we're kind of taking I think we look at perinatal mood disorders, we look at perinatal issues, and then I think we're going to do is like just twist it a little bit and look at it from a different angle. And I love that because, how many conversations can we have around postpartum depression or postpartum anxiety? But we can have many, many conversations around the struggle of parenthood and motherhood and becoming a parent and continuing to be a parent over time. But just that transition into parenthood and motherhood for the purpose of this conversation. Before we get into the actual discussion, can you tell our audience a little bit about who you are professionally?
Yeah. So my name's Hilary Waller, and I'm a licensed professional counselor in PA. I work at the Postpartum Stress Center as a therapist. I have been working in this field 11 years, and I truly couldn't love and feel more privileged to work with parents at this stage in life. It's such an incredibly rewarding journey to witness. And so one of the nice things that I get to do in my career is I do a lot of training. I do a lot of teaching for therapists, experienced therapists who are looking to specialize, newer therapists that are looking both to specialize and just sort of grow their career. And I also do a lot of work with parents. And I think that in and outside the therapy room. And one of the things one of the messages that I love to convey so much is that the parenting journey is one that is, it will cause you to feel like you are falling to pieces. And then the journey of being put back together is beautiful in unspeakably incredible and profound ways. So that's what I'm really thrilled to get to chat a little bit about today. How do we, give not only parents with mood disorders, but also parents that are just becoming parents, skills to move through that.
And I think that one of the things when I hear you describe that idea of being put back together, to me, I feel like as a parent, I feel like sometimes you're broken up into pieces and then put back together and then broken into pieces all over again. You're like, wait a minute, how did I end up right back where I was before? Maybe with a little bit more knowledge about being a parent. But I think that there's just, it's so frustrating, I think, as parents and becoming parents and continuing to be parents over many years is this idea of like, where's the guidebook? Like, where's the manual about how to do this? And how profoundly complex that can be. And especially you throw in mental health conditions or mental health struggles, and it becomes this very big idea. Let's break this down. I want to introduce the term matrescence. Talk to me about how you define the term matrescence.
Yeah. Okay. So I love this term matrescence, and I can't take any credit for it. I'll give the credit to Dr. Alexandra Sachs. She and Catherine Berndorf, who are both located in New York City, wrote a really fantastic book that covered this topic a number of years ago. And if you look up Dr. Alexandra Sachs' TED Talk, there's a New York Times article. She writes really beautifully about this idea of matrescence. What I pull from it that I like so much is a really nice comparison to adolescence. I think particularly in talking with women, right? We could kind of go into all the gender related stuff probably in another episode of this podcast, but particularly when we're talking about women's experiences in adolescence, right? There's a lot of focus on how do we look? How are our bodies changing? Who are we becoming? How does our skin look? How does our hair look? How do we function in the world? Who are our friends, et cetera, et cetera, et cetera, et cetera? What's our relationship to members of the opposite sex, et cetera, same sex, all of it. And I think that we're socialized to understand, teenagers,
Sure.
Right? Teenagers have a hard time. Teenagers are hard to raise. Adolescence is hard, right? And as mental health professionals, what we know is that adolescence is a time that is hard, where people are going to experience changes in body, moods, social, et cetera, and that it's a time that's especially ripe for the development of a mood disorder. So we know to be vigilant with teenagers around not only just their emotional well-being and emotional health, but also assessing them for, is there more kind of getting mixed up in this pot? So similarly, when you apply that, everything I just said to the experience of being perinatal, right, in the period in particular of new motherhood, we think about the changes to skin, the changes to body, the changes to hair, the changes to social, the changes in family structure, all of the changes that the brain doesn't quite have language for, right? And similarly, we've all been adolescents in our life, right? But it's really hard for me to talk to my current teenage daughter about my own adolescence in a way that speaks to her brain. Similarly, it's hard for me to speak to my postpartum niece about her postpartum experience, even though I've been through it. And so we experience this sort of, I think we experience this gap, right? When we're new teenagers, when we're new mothers, where we feel so isolated and alone. And it doesn't matter that everyone around us or most people around us have also been through it, right? We still feel alone. And what I like so much about this concept of matrescence is it helps those of us who've been through it to sort of remember, oh, this is a really, really difficult time. And I need to sort of sit and be present with this person in a unique way. It reminds the person who's in it, oh, this is a really, really difficult time. It's normal for me to feel like this is a difficult time. And I can call on the supports around me because we've all gone through this.
Right.
The last piece I'll say is that I think also for those of us who, quite honestly, for anyone who interacts with new parents, we've so normalized the experience of this dramatic adolescence, right? We should be normalizing the experience of everyone has mood changes, everyone feels unfamiliar in their own bodies, et cetera, et cetera. And we've overlooked that part. And I think that to some extent, we've actually swung in this direction where we're doing so much work to normalize mood disorders and coming forth with your symptoms of mood disorder. We now run the risk of ignoring, like, it's also really hard for everyone.
Right.
Right.
Right. Well, I think about also that idea of, I think that there's been a long history of normalizing by saying, like, oh yeah, everybody goes through that. Oh yeah, you're not going to stick to your 25. And like, oh, yeah, I had something like that too. It'll get better. And which really is, I don't love the word validation as much because I feel like it's, again, one of those overused terms, but it is invalidating when somebody says, I'm really, really exhausted. I can't keep my eyes open, or I don't feel like myself. And somebody says to them, oh yeah, me too. Right. Oh yeah, I also had a really hard time and it'll be fine, or like get used to it. And that minimization is the piece I think that people then feel very much alone. So like, oh yeah, I had it too, can feel invalidating and minimizing versus feeling connecting and supportive. What are you noticing? Let's take that thread of this idea of like, if we've swung so far to normalize, or I would say even highlight or amplify the voices of a perinatal mood disorder, of a mood disruption. I don't know that we should be normalizing it as much as acknowledging that there's a strong prevalence of that. Talk to me about what you wish the rhetoric would be. What do you wish the conversations would be that would amplify the importance of addressing a postpartum struggle or a perinatal struggle, in addition to kind of raising up the issue of, and yes, we understand that this is a common, I heard somebody use the word commonizing, which I love, right? It's not normalizing, but it's commonizing that term and that experience. How do you wish the narrative would look?
Yeah, thank you so much for kind of digging into that language a little bit. I think it's really important. And again, we could talk for a long time just about the language that we use to describe all of this, right? That question is a really, really simple one for me to answer. And what we should be normalizing, commonizing, call it whatever you want, is support, period. Emotional health support, emotional well-being support for every new parent. Because it's, again, like I described before, it's hard for the typical support people around us, parents, grandparents, members of clergy, people in the community, people in the schools, our peers, to kind of know how to say the right things. Even if they've been through it, they might say something like, I've been through this, it's hard. Well, to the person who's in it, that still might not feel just right. And so when we can offer some level of professional or trained support to every new parent and make that accessible for every new parent, then what we as trained professionals can do is sit with a new parent and sort of say to them, hey, here's what to expect. Here are signs of when something might be off. Is something off? I have resources to help you with that. Right.
Right.
So the best thing that I think we can do is really be normalizing, commonizing all of it, the contact with a mental health professional or someone who has trained skills to help new parents kind of wrestle with what's going on right now and what can we do about it, or what should we be looking for.
And yet, one of the greatest challenges we have, as you know, is access to care in terms of who's covering it, right? Like if I have multiple people who reach out to me and say, who takes insurance, right? Do you take insurance? Can you refer me to somebody who takes insurance? And finding somebody who is covered by, by an insurance provider, or to find somebody who takes insurance, is next to impossible when it comes to finding people who are trained. There are some support groups, and specifically in the Jewish community, we have very limited support groups around perinatal moods. We have more on infertility than we have, which is affecting 1 in 8 couples, versus perinatal mood disorders, which is impacting at least 1 in 5 women. And yet we have fantastic support groups for infertility, but not so many for the postpartum mom. So like, what do you, when you say we want to make sure that there's this access to support, in your imagination, and if you could be magical thinking with me for a moment, what would that look like on a practical level?
Well, let's see. I love that question so much. Let's see. There are some models for collaborative care that integrate behavioral health and emotional well-being health. And so as I see those kinds of projects sort of pop up around the country, I hope that they'll become more and more widespread. Integrating behavioral health, integrating even just basic psychoeducation, more than just sort of an OB or a midwife kind of noting this might happen, right?
Correct. Right.
I think is invaluable and can be, with some effort, integrated into the prenatal and postpartum system.
For sure.
So that's one piece of it. It's interesting. I also think I should say that ethically, as people who have this really highly specialized skill, it's our responsibility to find ways to give back to the community. And so when, I, just like you in my practice, receive lots and lots of phone calls for where do we go? And as I train and talk with more and more professionals and communities, the question, like, how do we overcome this gap? And until we have a system in place that's equitable and accessible, right?
Yeah.
I do think that ethically it's in part our responsibility to give back to the community to some extent. So for that reason, I will assess clients who may not be able to have who might not be able to access the full gamut of my services. And I will give them tools and resources, and I will slide my scale for them. And so we all kind of working together. And I think, I'm sure you experience this. I'm sure this is part of your practice too, right? We all in parental and reproductive healthcare know this and work very hard to give back. And so letting patients know that we're here to listen and help guide them as best we possibly can. So that's part of it too. A lot of grassroots stuff. What you said about groups is really interesting, because I think it's actually part of the Matrescence challenge, right? In that when you have, so part of my clinical work, a big part of my clinical work now is reproductive trauma, grief, and loss. So I see the majority of the patients that I work with have some medical complexity for mom and or baby, some significant medical trauma around the pregnancy or the postpartum period, lots of infertility issues, et cetera. And I notice, and this is anecdotal, so you'll tell me if this is your observation too, but I noticed that when there's a problem that we can validate as a problem, right? I'm having fertility challenges. I have a baby who died. I have this problem, right? It seems to be an easier leap to help people get to a group support. I noticed that the follow through is higher. I noticed that the longing for it is more, versus when I'm working with a parent who has, mild, moderate, even moderate, severe postpartum depression or anxiety. The feedback is more like, I'm a new mom. Like, I don't have time for a group. It's hard to make space for a group.
I'm wondering how much of that also is like, it doesn't feel like mental health when I'm dealing with infertility. And it doesn't feel like mental health or mental illness when I am dealing with, significant grief related issues. And it really isn't mental health in the same way, right? And so we are we know that there's a significant prevalence of mental health disorders that develop with people who are dealing with chronic infertility, but it isn't the same conversation. And so I wonder if that's where we're hearing that stigma voice of like accessing this kind of care feels very different. I'm almost like outing myself that my problem is bigger than I just had a baby and it's normal.
Right. Right. And actually, I wonder if that's why we see, you know, I can think about all of the places in my neighborhood, right? All of the new moms groups that gather formally and informally, right? Like I can think of the clusters of strollers, right? Where moms just sort of cling to each other, you know, in parking lots and at daycare drop off for their older kids or whatever it is. And then don't move that cluster into a group, right? They just sort of cluster on their own. And I think that it says so much about what we really need as new parents, which is social support. And so to the extent that we as therapists can offer spaces for that, you know, I find such great joy when I have the opportunity to bring groups of moms together. But you're so right that when we're treating, you know, a lot of the infertility work, a lot of the grief and loss work it's sort of protecting against developing the mental health disorders and the mood disorders. And so feeling camaraderie and peer support and feeling seen by someone who's sharing your experience is what's, you know, I think so powerful for those groups. Right. Versus you're so right, the mental health component of I'm here for my postpartum depression, you know? Right.
I do have to acknowledge that I think sometimes the struggle that we have with the groups in general is that many of these groups are during the daytime. And so there's always that certain level of privilege of people who are available during the daytime to attend a group, right? I'm still working with moms who are like hiding in the car because that's during lunch hour, during work, where that's the only time they're able to access a therapy session. You know, so we eat our lunch together in the cars, right? Like we have that, But but I think the reality is that those group spaces, even those drop-off spaces, to be able to stay and chat with these other moms holds a certain level of privilege. So now we're already cutting off a certain population of people who are back at work at 6 to 8 weeks later and have no access to this kind of support. Just like, I feel like we just have to name it. We have to put it out there that it's a certain level of opportunity that's available for those that are not going back to work, but yet also probably need as much, if not more, support as well. Right. Go ahead.
I was just going to say, you've like found me on my soapbox now. This is like my number one. I can talk until I'm blue about how, I can say I can talk until I'm blue and then I'm at a loss for words, right? Like unbelievably, unbelievably cruel we can be to new mothers. And how, you know, when you ask me like, how can we help connect mothers who need, which again, all mothers, how can we connect all new mothers to someone who can help them feel educated, empowered, aware of their own mental health, right? Able to advocate for their own mental health when they're busy being back at work at 6 weeks postpartum. Like their milk supply may not be in if they're breastfeeding and they're back at work. I can't. So again, I really think that while the system is so broken for so many, really looking for creative places. And I'll also say that an important part of the training that I give is to non-maternal mental health professionals, non-reproductive mental health professionals, because there's absolutely no reason that a preschool administrator, right, can't have a really warm conversation with a new parent. These are services that are not behavioral health related necessarily. They're opening doors. And so the more as therapists, we can start to train other people who interact with new parents in settings that new parents are already in, right? The better.
Yeah, I've had this conversation with my students when I teach in my master's level program at Worthweiler, and I'll have students who are saying to me, I have no interest in doing this kind of work. I just want to work with kids. I'm like, who do you think are the moms of the kids that you're going to be working with? You have that dysregulated child who comes in who like, you know, lunch with 2 pieces of bread and nothing in between. And you're going to start questioning neglect at home. Does anybody ask how old the new baby is? Right. So don't look at these children in isolation. We're looking at this experience as a family issue. That's one of the things that I know PSI has been working, Postpartum Support International has been working a bit on kind of shifting the language a little bit from perinatal mental health to parental, meaning that this idea of like, this is about parenthood. It's not just a her problem or a they problem. This is a shared experience of impacting the system, like definitely impacting the system. When we talk, you mentioned to me in our conversation before this idea of like, I want to normalize help seeking versus the focus on mood and mood disorders. Talk to me about like the overlap when you think about the two, kind of where that middle section of, well, actually, this is a concern about mental illness. This is a concern that we have something that's developed here. We don't want to just, say, well, we just get a little bit of support and everything will get better. Obviously, I'm trivializing the wording, but talk to me about how you, as a therapist, differentiate between normal help seeking, support seeking versus actually, we really have to get you medical care because of the severity of symptoms. Like when you assess a patient, tell me about, for the audiences that might be listening, what are you thinking about?
Yeah. What's the trajectory there? Like, what's the decision tree? I can walk through that a little bit. First of all, I think that, one of the pieces to really consider in my, my sort of magic wand plan, right?
Sure.
Is that we all go, most of us take our kids to the pediatrician. I was going to say, go to our OBGYNs or go to our own primaries, but the reality we know empirically is that adults don't do that for themselves as well as they do for their kids. So we take our kids to the pediatrician. We maybe go to our annual medical visits with some regularity. We get our teeth cleaned. We do these things routinely because we know even if we're late for our appointments, we need to take care of these things. And yet somehow we don't take care of our mental health this way. We don't take care of our emotional health this way. And so there's sort of the rare, amazing physician who will say to each of their patients, like, hey, how are you doing? Give a full depression screening, give an anxiety screening, really do a full biopsychosocial. But that's very difficult to come by, especially in our managed healthcare world. So I think it's, I think a shift that we can start to make as consumers and also as providers is really encouraging, as providers, encouraging people, come in for your mental health checkup, right? How are you doing? Let's just take stock. And as consumers, to be reaching out to providers and saying, hey, I'm doing okay right now, but I'd like to come in and just have a relationship with a therapist in case I'm not doing okay at some point, and having space for that. I think that in terms of decision making, when I receive a phone call from someone who's a new parent who says, I have no idea if I'm struggling or not, but I need to come in and talk. What I'm looking at is first, what are the acute symptoms in front of me, and how severe? So in other words, how life disrupting are they? And so I'm using sort of a clinical decision making tree to determine, well, this person's in need of acute help in terms of safety, keeping herself safe. And so if a person is in need of keeping herself safe from self-harm, harm to others, suicide perhaps, which is very common in the maternal health population, the postpartum mental health population specifically, then we act to protect mom. So that means bringing in additional support people. It means sometimes a referral to an emergency room. It means a psychiatric referral, but it means doing everything that we can to make sure that mom is getting the immediate intervention that she needs to keep her safe. And most importantly, to keep her feeling like a good mom, despite the fact that she's struggling so much, right?
Right.
The goal, no matter how serious and severe the intervention feels, right? I never want to separate a mom from her baby, ever, 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 ever. And so when I'm with a mom who starts to talk about suicidal thoughts, who starts to talk about symptoms that really require medical intervention and urgent medical intervention, my first message is, listen, these are symptoms. I know how to recognize them. I know that you love your baby. I know that your baby is in safe hands with your family. So let's figure out how to make sure that we can get you the help that you need and find a place for your baby to be cared for that feels safe and good to you, right? So I want
to put a pause on that because I want to acknowledge one of the complexities that we have around accessing inpatient care is that there are no hospitals in this country that I am aware of at this time, any psychiatric facilities or advanced care placements where there is the ability to keep the baby on the unit with mom. So even if we really are not terribly concerned about, we're not worried about mom taking care of the baby, but we are concerned that mom is really sick. Mom is really, really struggling. because of liability and the structure of the United States healthcare system, we don't have the access to an inpatient unit where mom will not be separated from that baby.
Right.
And so again, come back to that assumption that we make that there is someone else to take care of that newborn. And you and I have both been involved in situations where mom goes, well, there isn't anybody else to take care of my baby. Maybe I'm a single parent. Maybe my husband works full time. Maybe he has no access to any kind of family medical leave. Maybe parents live in another country and I don't have anybody to leave my baby with. So you're going to have to help me figure out a way to take care of myself with all my feelings as well as with my baby. And that I think is one of the scariest things as a therapist, to be like, we don't think this is a really good idea, but we don't know what to do other than to just do. But I think that my understanding is that in other countries, there are options for mom to have baby at bedside under certain circumstances. But that is not something, even the perinatal specialized inpatient units, of which there are several in the United States, they are not allowing babies at bedside. Babies can visit, which is different than in a regular psychiatric hospital. But that idea of separating from baby is very scary to a new parent.
And that's why, I mean, we absolutely should do another episode on just like that level of intervention. How do you do that as a therapist, right? But I cannot underscore enough, and I mean this very literally, like practicing in the mirror, practicing with a colleague, a partner, a supervisor, whatever, practicing having this conversation that conveys to the patient, any decision that I make for you, with you, on your behalf, all recommendations are to make sure that I can ensure that you know what a good mom you are for this baby, that this baby needs you, this baby is better off with you. And when that means we have to hospitalize you and baby can't be with you, whatever that looks like, I am supporting you in bringing this back together, bringing the two of you back together. That is like of the utmost importance to convey to mothers and to reinforce.
Yeah. And I will say as well, because I think it's just, we have to drop this in here. This is not a child protective services call. This is not a DHS CPS call. This is a sick mom. Mom is sick. Mom is struggling with a mental health issues. We would never call CPS if mom had a heart condition. Like that would never be even on our radar. And yet when it comes to where we are worried that mom is not well enough to care for the baby under mental health conditions, suddenly CPS and DHS gets involved. But when there is safe placement for that baby with a family member or a partner or a mom or a neighbor or a community member, this is not a DHS call. And I just feel like it's like always a reminder that we have to care for her medically first.
Yep, absolutely. I'm going to pause here because otherwise we won't get to the rest of the spectrum of stuff, and we should come back to that.
Go for it.
Okay, so then on the other side of the spectrum are those parents who are sort of like, you know, I'm feeling emotional. I'm feeling a little not like myself. I feel like a lot is changing, but I'm kind of okay with that. This is sort of meeting my expectations. I really wish that I felt, you know, better about my body. I'm not sure how I feel about my birth. I feel a little disconnected from my partner. I'm a little anxious, right? Those are the parents who I would say kind of fall into this, like, you know, give a lot of psychoeducation about what are the signs and symptoms of perinatal mood or anxiety disorder. I explore risk factors extensively with anybody who comes through my office, especially those who appear more mild. I really want to look at what are your risk factors for the development of a perinatal mood and anxiety disorder. And then we'll go through point by point, how can we mitigate any of that risk? That's part of my prenatal care as well for someone who just wants to come in prenatally and start to make a plan. Someone who comes in and says, I have a history of anxiety, can you help me? So we really are looking for risk mitigation. So for example, someone who comes in and says, yeah, like I'm doing pretty well, I'm a little bit emotional, but this sort of meets what I expected. I just wanted to check in. And I find out, let's say that they have a supportive spouse who works 12 hours a day and travels 3 times a month, right? Then I will say to them, wow, that sounds like you have a really wonderful and loving relationship, but that's a big stressor. So can we start to problem solve around getting you more support during those times, for example?
Right.
And then giving the invitation, if these plans aren't working, if you feel overwhelmed, if anything changes at all, check in again and we'll do this again, right?
Right.
And then there's sort of that middle group, right? I'm a big believer, by the way, Deborah, in empowerment and education. I think one of the reasons that we struggle so much to identify women who need help is women just don't know when to ask, how to ask, what's normal, what's not. And so by empowering women and the people around them, right? Birthing parents and the people around them about what these mood disorders look like, that you can feel great and then you can feel terrible. Things change very rapidly during the first year or two postpartum. And so if not only in mom, in the baby, look at what happens for a baby between the ages of birth and 2, right? So much is happening, so much adjustment. And so empowering the people who are in this moment to with information, to teach them how to ask, to teach them to advocate for themselves, and then to welcome that, I think is a really important service we offer to all parents. And then there's that group in the middle who, present with some symptoms of anxiety, depression, maybe OCD, PTSD, panic. And I would say that that's the majority of the people that that land in kind of regular outpatient treatment, where, we see the spectrum of mild, moderate, severe symptoms. And my goal is always to, as you were describing, do as much bonding work between mom and baby as we can to build as much of a support system around the mom and her baby as we can. And then utilize kind of a mixture of what I learned in school as a therapist, right? Like the things that I learned academically about how to treat mood disorders, and blend that with the really nuanced needs of a brand new parent. So that's,
Beautiful.
yeah.
I love listening to you. I'm just in light of time, I'm wondering if we could take a minute or so and talk about, what would you say, as we wrap up today's conversation, what would you say are the top 3 misconceptions that you wish people understood around perinatal mood disorders and let's say matrescence, or matrescence in general?
Wow, what a really, really great question. I'm so on the spot with that one. Okay, the three misconceptions.
Yeah.
Okay, I'll give you a couple of let's say 3 important points. Number 1, I think, is that it's something to be ashamed of. It's something to be reluctant to talk about. These beliefs can be cultural. These beliefs can be cultural in terms of community culture. They can be cultural in terms of family system. They can be cultural in terms of like, well, my sister had 4 babies and never suffered, and I have 1 baby and now I'm really symptomatic. There's a lot of shame around experiencing mood symptoms. And so one of the misunderstandings that I want to make very, very clear is that the shame that patients feel is part of the disorder. And
Beautiful.
so when you start to notice that feeling of shame, find your way to someone who you can emotionally safely say, I'm not sure how I'm feeling. I'm not sure if I'm okay. Can you help me? Access someone to talk about, right? To talk with. So that's number 1. Number 2 is that partners are immune. Actually, that anyone is immune. There is no one immune to the development of a perinatal mood or anxiety disorder, and there's no one immune to the adjustment to parenthood when you've had a kid. So really monitoring, I love what you're telling me about PSI and the family system. I'm a family systems trained therapist, so I love this. But really acknowledging the impact of that baby on the family system, and thinking about things like, what is it like for a partner to watch their partner give birth, right? Under the best of circumstances, that is an overwhelming and new experience, right? We're witnessing our partner experience lots and lots of pain, discomfort, again, in the most beautiful, perfect birthing settings, right? And then we see the whole range of all kinds of births, right? Yeah. And so are we really paying attention to the lived experience of those who witness that? So that's number 2. It's not just about mom and baby. It's also about the whole family system and the experience of every part of it, from being sort of, with fertility patients, the sidelined partner, right? Who doesn't have much to participate. And then in the birth, the sidelined partner who has to sit and be the cheerleader and maybe experiencing a wide range of emotions, and then so on and so forth. Excellent. And the last piece is that, again, to kind of echo what you're describing, PSI is moving toward, the more I work in maternal mental health and postpartum mental health, the more I think about reproductive journey as opposed to like the having a baby period, because the experience of having a baby, the experience of family planning, right? Whether you have children or not, actually, is so unbelievably and profoundly impactful that people will say to me, I don't have children and I'm not going to have children and I'm 50 years old. Like, are you the right therapist for me? And I answer yes, because I may not be for that individual, but in terms of my training, being able to look at the nuances of family planning is really an important part of what we do. So if you are someone who's listening, who is sort of grappling with stuff around transition to parenthood, the loss of your own parents, transitioning to grandparenthood, any stage of life that has to do with these kinds of milestones, consider seeing a reproductive mental health provider, because part of what we do is to really understand the complexity of these life adjustments. And that would be
I know, I
really
think that's great. I love every one of the things you just said. And I also think that I was thinking about that reproductive journey, even at the end of the story, like wherever that end may lead you. Is it those unfulfilled dreams? Is it the, I had to have a hysterectomy? Is it the, I had to stop having children because my husband didn't want me to have any more children, right?
Yes.
Those are all, or what about just flat out, I had everything that I ever wanted in life relating to my children. And now I'm starting to go into menopause and I wasn't prepared for the emotional disruptions that that would cause.
Yep.
Or I'm actually sad that that part of my life is over, or I'm excited that that part of my, those are all part of the process of the reproductive story. And I think that especially the stuff on the other end of the spectrum gets completely kind of like I think the assumption is that it's great rather than the assumption is that well, actually, it might not be so great. And can we talk about it? I love, like, Oprah recently has done a huge series on the menopause, and like, can we please just talk about menopause and what that is like? And I think that's fabulous. I do miss her platform, I must say. Hilary, it has been such a pleasure talking to you. As I agree, we can always identify, and every person I meet and had these conversations with is always like, oh, well, we should talk about that. Oh, we should talk about that. So I'm making notes about the things we need to come back and talk about. Thank you so much for spending the time with me today and sharing your wisdom and knowledge and experience.
Thank you so much. It's always it's a great pleasure to talk with you, and I'm so happy to support you in this new endeavor in your professional journey, and to be able to share my voice with your listeners. And thank you so much for inviting me.
Such a pleasure.